Good evening, everyone. Welcome for joining us. We're just going to wait a few more minutes for other people to come on. Thank you for your patience. Okay, and I think we will get started. Good evening, everyone. I'm Laura Kurtzfeld, the lead vaccine outreach coordinator to the Orthodox Jewish community for the Baltimore City Health Department's Value Baltimore initiative. On behalf of the BCHD and the Associated, I want to welcome everyone and thank you all for joining tonight's event. We are honored to have such distinguished experts in the fields of local government, the rabbinate, epidemiology, healthcare, and public health with us. In addition to Councilman Yitzy Schleifer, Rabbi Jonathan Seidemann, Dr. Kendra McDowell, Dr. Naor Barzeev, and Dr. Susan Lipton, we are proud to also have Dr. Susan Dienstag Becker of the Jewish Orthodox Women's Medical Association with us as well. And before we get started, I do want to thank Dr. Cheryl Cooper for providing sign language interpretation for the event. We know that in our community, there is much support for but also much concern about COVID-19 vaccines. You have been hearing a lot about the Value Baltimore initiative for several months, and you may have also encountered some of our vaccine peer ambassadors providing educational materials, answering questions, and registering people for vaccine appointments at canvassing or tabling efforts throughout the Park Heights JCC, food distribution lines, pop-up vendor sites, and other community activities. This town hall event is an extension of these efforts, designed to address those many concerns that people have expressed in public and in private. So let's bring this all out to the floor and talk about it. We'll start with a message from our esteemed Councilman Yitzy Schleifer, representing District 5 of Baltimore City. Councilman Schleifer.
Good evening. Thank you, Laura, for that introduction. And thank you to everyone who has taken the time out to be on this town hall. COVID-19 has been an evolving situation, and I understand how overwhelming and frustrating it must be with lots of information and also disinformation being put out there. So thank you for joining us for this important town hall to learn and to hear from the experts on this panel. I just want to take you back to March 6th of 2020, before Purim of that year, when the largest schools in the community had large masivas planned. I had called for a meeting with school executives that had big events on the books and requested that they not do it. At the time, it was a controversial decision because there had not been a single positive case in Baltimore City. I got calls from community leaders and constituents calling me crazy. And they might not be wrong, but they were wrong about this topic. And for the next 2 weeks before Baltimore's first positive case was confirmed, I couldn't walk into a supermarket without being ridiculed about this decision. A few weeks after Purim, when people were getting sick and dying left and right in New York, New Jersey, Florida, California, and many of those cases were traced back to Purim events, Baltimore thankfully did not have the same catastrophic experience. How we started plays a huge role in how we will finish this pandemic. At the height of COVID, I was receiving daily calls from constituents from begging for help for their loved ones to get a hospital room or to get them the attention they needed, or simply to just allow a family member to visit them. A year ago today, it would have been impossible to imagine that people would have such short memories and would be rejecting the single biggest tool to help us get out of this pandemic, and that is the vaccine. It has also been very eye-opening to see how many new scientists are popping up every day and giving reasons why they did not want to get the vaccine. Before this pandemic, it was pretty customary to listen to the advice of your faith leaders or your doctors. And yet every leader that I'm aware of in my district has been very supportive of getting the vaccine. I was able to understand the hesitation when it was first rolled out and prior to CDC approval. But what I'm seeing now is that those who don't consider themselves anti-vax, just anti this vaccine, despite the recommendations of their doctors, are continuously moving the goalposts and are the reason we are not at herd immunity today. Ironically enough, those same folks who are hesitant to receive the CDC-approved vaccine don't hesitate to receive experimental treatments when they are getting very sick. This experimental treatments and those who receive the vaccine are the reasons we are not experiencing as many deaths as we would have if our spread had occurred in March and April of 2020 instead of in 2021. You will hear from our panelists tonight about the increased ratio of sickness and death among the unvaccinated versus the vaccinated. The bottom line is the numbers don't lie. The lowest positive rates in the area are a direct correlation to those areas that have the highest vaccine rates. Thanks to Becker, the Associated, the Baltimore City Health Department, it is just as easy today to get the vaccine as it is a cup of coffee. If you haven't gotten the vaccine for yourself, at least go and get the vaccine for your family, neighbors, and community. Thank you very much.
Thank you very much, Councilman Schleifer. Before I continue, if you have a question that you did not submit earlier, please enter it into the private Q&A chat to me, and we will try to get to all the questions. Next up is Rabbi Jonathan Seidemann, the Rabbi of Kehilath B'nai Torah. Rabbi Seidemann, please tell us what the Rabbanim of our community experience and how they address questions concerning vaccination.
Thank you, Mrs. Kurtzfeld, for putting this town hall together. Thank you, Councilman Schleifer, for your very informative remarks at the outset. And thank you to all the medical professionals who are really on the front lines and are going to help, God willing, bring us out of this pandemic, and you join us this evening as well. In answering Mrs. Kurtzfeld's first question, really what the local rabbinate is doing, has been doing, etc. Thank God we're so filled with gratitude for this really tremendous miracle and gift that God has given us of the vaccines. This has really been a record time in history. We've never seen anything like this, that a vaccine that's so necessary, so required, has been able to really been brought from the laboratory into the arms of citizens so quickly. And we need to really realize the beauty and the specialness of this moment in time, and to take advantage of it. The local rabbinate has been very proactive, both in the pulpit and bulletins, letters that we've put out on behalf of the Vad HaRabbanim, the Rabbinical Council of Greater Baltimore, the constant letters we've put out. We worked together with the Associated in the Baltimore City County Health, Baltimore City Health Department, under the leadership of the value leader, Mrs. Kurtzfeld, to put together a video really putting forth the message, the importance of the message of the vaccines. And actually, thank God, it was deemed so successful that if imitation is the sincerest form of flattery, this video actually was replicated by rabbis almost word for word, format for format, in other communities as well. Mrs. Kurtzfeld, the moderator, mentioned that we should perhaps let's take a moment to analyze some of the questions that are out there. As Councilman Schleifer had indicated, there's somewhat of a curiosity that people who don't hesitate when it comes to other matters, all of a sudden in certain circles, thank God not to large circles, but every so often you see certain hesitancy with the vaccine and yet not hesitancy with the unproven therapeutic. And one of the questions that has been presented to me is that there is a law that we have in the Shulchan Aruch, in the Code of Jewish Law. And that law says, and that's talking about the holiest day of the year on Yom Kippur, when every Jew has to fast from sundown to sundown. And the law says as follows: we know that a sick person is not supposed to fast. A person who his illness would preclude him from safely fasting is not supposed to fast. Now, what if there's a dispute between the physicians about the condition of the patient? Should he fast or should he not fast? So we err on the side of saving human life. We err on the side of caution when it comes to health. And the Code of Jewish Law tells us in Siman Tafresh Yud Ches that I'm going to have compassion upon our interpreter, Dr. Cooper. You don't need to translate which chapter and verse that is. But in any case, right, we're good. In any case, the Code of Jewish Law tells us that if, for instance, there are 100 doctors and 98 of the doctors say the patient can safely fast, there will not be any effect, no adverse consequences to his health. And yet 2 doctors say, no, this is an adverse situation for the patient to fast, and therefore he should not fast. So Jewish law mandates that even though it's only 2 out of 100, we listen to the minority view. We do not take a chance when it comes to saving a life. And therefore the question has been asked, well, I can find 2% of doctors, although I don't even know whether that's true, that you'll find 2% of doctors who are nervous about the vaccine, but let's accept that argument just for the moment, for the sake of the question. There are people who will say, I can find 2% of the doctors who are against the vaccine, who consider the vaccine to be a dangerous thing, to consider it to be untested. It's been the same point that we're touting as a gift from God, from heaven, a blessing that God gave the scientists, the doctors, the wisdom to be able to implement this vaccine in a record time. So others will say, well, you're calling it a gift, Rabbi, but maybe it's too short of a timetable. It's untested. No vaccine has ever been brought to market in such a short time frame. And therefore, if I can find 2% of the medical community that will sound the alarm and say that this is dangerous, doesn't that mean that for the sake of saving a life, I should go ahead and I should listen to the 2%? And the answer is that actually, their conclusion should be just the opposite. They're taking it completely out of context. There, the question is, should the patient fast? Should he not fast? So we know if he eats, he certainly will not be endangering his health. The question is, he'll be violating Jewish law, possibly. Or do you say that maybe the 2% who say he needs to eat are correct, and in which case he'll be violating Jewish law if he does fast and he'll be endangering himself? So it really has no relevance to the case of the question of the vaccines. In fact, it's quite the opposite. The law normally in Judaic law is that you follow the majority. That's true when it's a question of halacha, of Jewish law. That's true when it's a question of engineering a building. What should the code be or not be? You follow the majority. And it's certainly true in medicine. You follow the majority. So over here, it's just the opposite. If a person cares about saving lives, then he really doesn't have an option but to follow the majority who say that this is what a person must do to save lives, and certainly to save his own life.
Thank you so much, Rabbi Seidemann. Next, we will hear from Dr. Kendra McDowell, the Chief Medical Officer of the Baltimore City Health Department. Dr. McDowell, can you please tell us about Baltimore City Health Department's relationship with the Orthodox community and some important new updates affecting us and all of Baltimore City?
Yes, good evening, everyone. First, I do want to say thank you so much to Laura Kirkfield for the invitation to participate on this panel, this important town hall, and also to Councilmember Schleifer and Rabbi Seidemann. As was mentioned, the Jewish Orthodox value communities, Baltimore City Health Department has 8 value communities, with the Jewish Orthodox community being one of them. And the purpose of our value communities is to make sure that we are bringing vaccine to those particular communities to make sure that we are addressing vaccine hesitancy, we are connecting with the community, and most importantly, building trust. Since January, February, Baltimore City Health Department has been working with the Associated and also other leaders within the community to ensure equitable vaccine access, and also, most importantly, to ensure that individuals from the community are getting their questions answered. I do have a quick presentation, but I do want to also mention, very importantly, that as Rabbi Seidemann mentioned, the Jewish Orthodox community in Baltimore City has been on the forefront in regards to development of information, development of materials addressing vaccine hesitancy. Through the leadership of Laura Kirkfeld, the leadership of the Associated, the video that was developed, as mentioned, was spread throughout the United States through multiple communities in addressing head on from religious leaders why the vaccine is so important. Lastly, I do want to mention a conversation that I had with Councilman Schleifer that stayed with me early on. I believe it was probably sometime in the last winter, possibly. And it was mentioned that if you can save one life, you have saved the world, you have saved humanity. In this vaccination, the COVID-19 vaccine is so important because if an individual is vaccinated, they are reducing the chances of spreading the vaccine to someone else that cannot get vaccinated because of their age or potentially an allergy to the vaccine, or even another situation. For example, someone that might be immunocompromised that was vaccinated, but might have difficulty having an immune response and developing that strong protection to the vaccine. So I think that is just a very important ethos and moral obligation around being vaccinated, saving that one life, having that one person being vaccinated really is saving humanity. And that really is the purpose of public health on the population level. So I'm just going to share my screen. So just give me 1 second and go into a little bit more about what the health department is doing around booster vaccinations and also around pediatric vaccine planning. So quickly, the health department has a vaccination dashboard. As you can see, you can go to coronavirus.baltimorecity.gov, and I will also drop the information to the dashboard in the chat box. This data is as of the 21st, so it's not updated over the weekend, but it will be updated on Monday, usually around 10 to 11 a.m. So in terms of the eligible populations, individuals that can get vaccinated are 12 and older currently. In Baltimore City, 68.5% of the eligible population has had at least a single dose, our first dose of the vaccine. 60.8% of the eligible population, 12 and older, are fully vaccinated. So I'll skip over that. In regards to the booster doses, so currently booster doses, Pfizer booster is available through health department vaccination sites, through your pharmacist, and also through your healthcare provider. What is a booster dose? So a booster dose is another dose of the vaccine given to someone who has built protection from disease after vaccination. So they have that immunity from the vaccine. However, the protection from the vaccine starts to wane or decrease over time. Because of this, an individual might need a booster, so an additional dose to basically ramp up that protection. I'm a pediatrician, and in pediatrics, we give booster doses all the time. This is not a new concept. What we know is that in the setting of the Delta variant, we are seeing decreased protection against mild and moderate COVID-19. However, the vaccine still protects us against severe disease that causes hospitalization and also death from COVID-19. Recently, the FDA and CDC have recommended and authorized booster doses for both the Pfizer and Moderna vaccine 6 months after completion of after the second dose. The Johnson & Johnson vaccine, the booster dose is recommended at least 2 months after getting that single dose. Also, the FDA and the CDC are saying that you can consider mixing and matching doses. So for example, if you receive the Johnson & Johnson vaccine, you can decide to receive the Pfizer or Moderna vaccine for your booster. The same thing with if you received the Pfizer vaccine or the Moderna vaccine, you can decide to receive another vaccine manufacturer for your booster. There is evidence that this mixing and matching is okay, it's safe, it's effective, and then also it helps increase the vaccine efficacy, so that response, your immune response to the vaccination. The NIH did an extensive study on this, and this data is actually available, publicly available at the New England Journal of Medicine, or just going to cdc.gov, and you can read high level about mixing and matching of doses. So who is eligible for the vaccine? So for the booster dose. So for the Moderna and the Pfizer booster doses, you should receive the booster if you are 65 and older, or an adult that's a resident of a long-term care setting. Also, if you are between 50 to 64 and have certain underlying medical conditions as listed here, and I know some of the clinicians that are on this call are going to give a little bit more information about certain populations that might be at risk of COVID-19 and should really be getting the booster dose and their initial vaccine. Lastly, you may decide to receive the booster if you are 18 to 49 and you have the above underlying medical conditions, or you live or work in an area that increases your risk of being exposed to COVID-19, or there's increased risk of spreading the virus to others. First responders, our education staff, our grocery store workers, our public transit, correction workers, and also US Postal Service workers. So who is eligible for the Janssen and the Johnson & Johnson booster? CDC is recommending that if you receive the Johnson & Johnson booster, Johnson & Johnson initial vaccine, then you should definitely get the second booster dose. That second booster of J&J, or that second booster of Moderna or Pfizer, at least 2 months after you got the first J&J dose. This is only for adults right now at this time. So where can you get vaccinated in Baltimore City? As Councilman Schleifer mentioned, vaccine is available, particularly because of the strong work of Becker, of the Maryland Department of Health, Baltimore City Health Department, and many of our community partners and clinical partners throughout the city. You can go to Maryland has a site, as you can see there, and just Google Maryland Vaccination Finder, and that webpage will pop up. Or you can also go to Baltimore City Health Department weekly vaccination clinics. There are approximately 20 to 25 vaccination clinics that are held on a weekly basis that the Baltimore City Health Department holds with community partners. Do you need to show proof of eligibility for the vaccine? No, you do not. We want to decrease any barriers to vaccination, so you can self-attest. You don't need a doctor's note or a prescription. You do, however, need to bring proof of your prior vaccination. So the CDC card, if you do not have the CDC card, you can go to md.myir.net. That's the Maryland Department of Health vaccination record, and you can just go in there and find your vaccination information. You can also go to your primary care doctor and let them know that I need a copy of my Immunet or my vaccination record, and they can print that out. We know that this is respiratory disease season, so this is flu season as well. And we want to make sure that we are preventing any twindemic of flu and COVID-19. So strongly urge everyone on the call to get their flu vaccine. And yes, you can get both at the same time. You can get the flu vaccine and the COVID vaccine, or the COVID vaccine and another vaccine at the same time. There's believed to be no increased risk or side effects. So just going into a little bit deeper about 5 to 11-year-olds. So the vaccine, Pfizer is submitted their data to the FDA for pediatric vaccines for our 5 to 11-year-old population. Most likely, this vaccine will be authorized starting in November, the first week of November. What the health department is done to date around pediatric vaccinations is pediatrics is one of our value communities. So we know that parents are going to have questions about COVID-19 in children. They're going to have questions about the COVID-19 vaccine, and the health department and our community partners are here to answer those questions. To date, the health department has held 120 clinics for adolescents in particular, in partnership with city schools and our community partners. We will continue to hold vaccination clinics, particularly at our elementary schools and our middle schools, to focus on that 5 to 11-year-old population. In addition, pediatric providers, our family practice providers, we believe it is critical that we increase the capacity of our healthcare system, particularly our pediatric providers, that parents, caregivers have the trusted relationship with, to be able to administer the pediatric vaccine when it becomes available. Because of that, the health department has a direct outreach. We directly reach out to pediatric providers, call them up and see if they're administering the vaccine, to see if there's any issues with vaccine handling and administration. We also have a pediatric vaccine transfer program where we transfer vaccine from the health department to our pediatric providers, because some of our providers want to receive the vaccine in smaller batches that the Maryland Department of Health is unable to provide for them. This is a hub and spoke model. We also have vaccinations for the homebound. So these are individuals that might have difficulty leaving the home to access the vaccine. This is done in partnership with a number of partners, including the Baltimore City Fire Department, National Guard, Lutherville Pharmacy, LifeBridge, Becker has been at the meetings. Dina Pollard has been at our homebound meetings and actively involved, and University of Maryland Medical System are all working together to bring vaccines to individuals that are homebound. Thus far, we have vaccinated over 1,000 Baltimore City residents. Booster doses are also available for homebound individuals. And also, if there are children that are unable to leave the home for whatever reason, we also vaccinate our 12 and older population. And when the pediatric vaccine becomes available, we'll have that option as well. You can go to covax.baltimorecity.gov to register online, or you can call 443-984-8650 and set up a homebound appointment. It's about, honestly, like a 2-week turnaround. Decreasing barriers to vaccination. So transportation is available. If you or a loved one is unable to get to a vaccination clinic, you can call 410-372-3444 or email covidtransport@mjminnovations.com for free transportation to and from the vaccination clinic. Lastly, I want to really provide information about the health department's small grants programs or micro grants programs. This is really to allow communities that communities, first off, know community organizations, communities know their population the best. And so the health department is providing grants from $500 to $10,000 focused on our value communities. So those 8 value communities, to allow community organizations and individuals to set up vaccination events around vaccine hesitancy, vaccination clinics, and individuals can go to Civics Works, Baltimore City, if you Google that, and Laura, I can give you these slides as well. You can send them out and also apply for the potential of getting funding to spread the word around the vaccine. So I just wanted to say, again, thank you so much for this opportunity, and also to the wonderful work that is being done, particularly in the Jewish Orthodox community, around getting everyone vaccinated and also addressing vaccine deliberation and hesitancy in the community.
Thank you so much, Dr. McDowell, for all that incredible information. Thank you so much. Next, Dr. Naor Barzeev is the Associate Professor of International Health and Vaccine Sciences and Deputy Director of the International Vaccine Access Center at the Johns Hopkins Bloomberg School of Public Health. Dr. Barzeev, if you could please clarify some information for us about mRNA and vector vaccines and the perceived risks of vaccination that our audience may have. With boosters and additional doses in the news so much, people ask, why should I get vaccinated if I can still get and spread COVID-19?
Sure. So thank you very much for having me. And thank you also for the questions that have been coming in through the Q&A. I'd encourage you to keep asking. And thank you to the panelists, the other panelists. I'm going to keep my remarks fairly brief, and hopefully we can discuss more in the Q&A later. My expertise is in immunology and epidemiology and their interaction. Nowadays, everybody has become an expert in these issues. So, I'll probably be saying things that you've already heard. But fundamentally, the purpose of vaccination is to train the immune system so that it learns to recognize a pathogen, so that when and should an infection occur, that pathogen can be cleared quickly and avoid symptoms of disease and, of course, death. That's the purpose of the vaccine. The vaccines for COVID-19 were designed with the endpoint or with the outcomes of preventing disease, symptomatic disease, and preventing death. We had a period in which we were quite lucky to have vaccine efficacy that was so high that it seemed to also prevent infection and transmission. And they still do that. The vaccines do that against the original strains of COVID-19. But it's important to remember that that was a bonus. The real purpose of the vaccines is to prevent severe disease and death. And they
I apologize for the technical difficulties. Here comes Dr. Barzeev.
Sorry, my internet connection dropped. I apologize. The way that the vaccines work is that they deliver genetic information to the cells of the body, and they allow the natural mechanisms for presentation to the immune system of the so-called epitope, the part of the protein that is then recognized and is used to develop the mechanism to fight the infection should it occur. mRNA vaccines go into the cell at the outside of the nucleus in a place called the cytoplasm. The Johnson & Johnson vaccine can enter the nucleus also, but none of these vaccines is able to incorporate into human DNA. They lack the genetic mechanisms and the enzymes that are required to have that happen. So it's physically not possible for that to happen. Not into the cells of the body, not into reproductive cells in any way, shape, or form. The genetic material itself is degraded as very quickly within a matter of hours and doesn't remain in the body. But the immune system learns, and then the immune system, like all learning, needs to be boosted by a repeat exposure often. And we're seeing that now, information about the Johnson & Johnson, as we just heard from Dr. McDowell, that even with the Johnson & Johnson vaccine that worked after a single dose, there's benefit from a second dose for that very reason, that the immune memory is boosted by encountering the epitope again, and it learns and retains its memory for longer on second exposure. The same is with learning, of any form in the human mind as well. So I mentioned before that the vaccines work against disease and death, which is why they're used. And they do work to some degree against infection and transmission, but less so with the current new variants. And part of the reason for wanting to boost the immune response is so that we retain the prevention of transmission. And that's very important if we want to get on top of transmission in population. There were questions about herd immunity in the chat, for example, that I tried to address. The vaccines work against the severe end of the spectrum. And so even if I was to have a so-called breakthrough infection, I'm vaccinated, I have good immune memory, I have good immune protection, but it is possible that I will be exposed to COVID again, and that COVID will enter my body, replicate in my body, and potentially transmit onward to others. However, I'm much less likely to develop severe disease if I'm otherwise healthy. Clearly, there are some people, and we heard recently even famous important people like Colin Powell and so on, people who have underlying comorbidities do remain at risk. And that argues all the more for the rest of us taking up vaccination so that we can reduce transmission at population level, so that those around us who are vulnerable or in whom the vaccines may work less well because their underlying immune system is weaker, that they remain protected through the actions of the rest of us. So that's a very important principle, that vaccination works at population level as well as at the individual level. The risks of COVID-19 far outweigh the risks of vaccination. Vaccination is not 100% risk-free. There is no human action which is free of any risk. Vaccination carries risk, but it carries very commonly mild risk, sore arm, headache, fever. We've all experienced, those of us who've been vaccinated have experienced those symptoms. They're transient and they pass. And very rarely, severe outcomes can also occur. There can be severe adverse events from vaccination. There have even been deaths, very, very rarely, that have been associated possibly with vaccination. However, in terms of the individual risk and population risk, the risk of severe outcomes, including the very same ones that occur as side effects of vaccines, are orders of magnitude higher when it comes to COVID-19 disease than they are from the vaccination against COVID-19. For example, there was a study done in Israel looking at the rate of adverse events following vaccination and the rate of adverse events following disease. And again, even for those problems like myocarditis, which is inflammation of the heart, that was increased following vaccination, it was about 6-fold higher when it came to disease itself, if not more than that as well. So it's really a balance of risks and benefits. And I think I'm going to risk saying a technical point also, and that is that it's not only a relative benefit, but there's an absolute risk reduction also. You might say, for example, well, so long as there's COVID, then I'm willing to take the risk. But if COVID goes down, why should I take that risk? Well, it was shown in the Israeli study and in other studies that even in circumstances where the disease is now being controlled through population vaccination, that there remains a benefit of vaccination over and above the risks that occur from disease. So these are very important ideas, and it's important to internalize that, yes, there are risks from vaccination, but they are far safer. Vaccinating is far safer than remaining exposed to disease, to protect ourselves, to protect our loved ones, and to protect others. Can we still get COVID-19 if we get vaccinated? It's possible to get infection. It's very unlikely to have severe disease or to die from COVID-19 disease if you're vaccinated. There are famous cases that will be told that occur where that is not true. There are always exceptions to the rule, particularly in people who have other vulnerabilities. But that makes it even more incumbent on the rest of us to protect those people by all of us having higher levels of vaccination. I might briefly also want to address this question of variants. We've seen a number of variants emerge over the last few months. We had the P1 variant, we've had the South African variant, B1351, the so-called Beta variant. Now the world has been dominated by Delta variant. These variants occur because the virus, which is new to the human population, is evolving. There are different groups of the virus or clades within the virus. That's normal in all of biology. There's variation in nature. And by natural selection, there are some viruses that are more fit to transmit than others, either because they can evade the immune response, which occurred, for example, particularly with the Beta variant, or because they transmit very readily. And that's, for example, the situation with the Delta variant. And sometimes it's a combination of those two things. Sometimes, such an advantage can lead to the dominance of one variant over others and make it more challenging to fight against or to prevent the spread of those variants. There are arguments that say, well, if people are vaccinated, doesn't that select out the emergence of variants? And in our theoretical principle idea, yes, there is logic to that argument. But the real issue here is that if everybody was vaccinated to the degree that we could reduce transmission, then indeed we would be preventing the emergence of variants. The problem occurs when some people are vaccinated and other people are not vaccinated. Then there's a low level of selection pressure through those who are vaccinated, and an avid field for already a field for transmission among those who are unvaccinated. And so inequity in vaccine uptake and having pockets of ongoing vulnerability are a very good setup for the emergence of variants. But if everybody was to be vaccinated, even with an imperfect vaccine, then variants would not be emerging at the speed that we're seeing them. I think it's important to remember the experience with smallpox, which is a disease that's been eradicated from the earth. That disease is no longer circulating, and it was eradicated with a moderately good vaccine. It wasn't a very good vaccine at all. It was about 70% efficacious. But everybody who needed to get it, got it. And that's how we eradicated smallpox. And if we do the same, then we would hope that we'd be able to gain some control over COVID-19. We not fully eradicate it. It occurs in other species and so on, but we'll certainly be able to gain control over it. I think I'll close my remarks there, and then I'll be certainly open to responding to any questions that the audience might have. Thank you so much.
Thank you very, very much, Dr. Barzeev. Next, Dr. Susan Lipton is the Chief of the Division of Pediatric Infectious Diseases at Sinai Hospital of Baltimore, as well as the Chief of Maryland's American Academy of Pediatrics section on infectious diseases. Dr. Lipton, please address the perceived risks of vaccinating children that some of our audience may have, both for the teenage group and the 5 to 12-year-old age group.
Thank you. I did want to also cover something we spoke about, which was there's a perceived sense that children do not get terribly sick with COVID. And it is correct that indeed they make up a small population of who gets hospitalized, probably only about 2% of that, but there have been 6.2 million kids who've gotten COVID in the United States. And that becomes a significant number, and some of those have died. I do want to briefly, again, in looking at the risk benefit, I think you need to see the risk that has been most frightening to us. Could I have the first slide, please? There is a condition called MIS-C, which we did not learn about until roughly May of 2020. And MIS-C stands for multi-system inflammatory syndrome, COVID related. Today, this was the case statistics a couple of weeks ago, but we heard of a handful of cases in May of 2020, and it was a rather scary story. The average age of these kids was about 9 years old. Most of them were between 5 and 13. About a third each were Hispanic and Black, but a third were white and Asian. And all of them had in common either having had COVID go through the household and they're having minimum or no symptoms, testing positive, or at the time they became sick with MIS-C, having antibody. And it appears to be somewhere 2 to about 10 weeks after COVID disease, again, often asymptomatic, a very inappropriate immune response, really a storm by the immune system in reaction to the infection. It's called a vasculitis, meaning the blood vessels have an itis, they're inflamed, and blood vessels supply every organ. So what we were seeing was dramatic heart failure, circulatory collapse, dysfunction of the brain and the kidneys, and just about every organ system, and it was a terrifying disease. A handful of cases of this came out. That information was disseminated in rapid order by CDC, and from them to the Maryland Health Department, and every physician that's practicing in Maryland got a letter saying you must be on the lookout for this. These are the signs and symptoms, and this is what you need to do. The next day was the first death at Hopkins of somebody who was so sick they didn't make it from ER to the intensive care unit. And the next day at Sinai, we had ours, and it was very scary, but the child lived. In general, we picked up at Sinai, which again is itty bitty, 5 cases in the first part of the year. Then I've got another 12 cases that we're submitting in the past year, but we've gotten much better at knowing what to do. We did, in the period between then, also see kids who had more adult risk factors, like they were obese or diabetic or hypertensive, and they had the same shock lung syndrome maybe the week after COVID, and we got better at them, and we got better at not responding with tears to every time we heard the chimes that meant that somebody else at Sinai had died in the adult unit go off. And our mitzvah around Hanukkah last year was that finally, as frontline providers, we were going to be getting vaccinated, and a lot of people wept. It was very hard to get the vaccine until about April, even though it was approved down to 16. The big break came between around May 12th, when kids 12 and up were authorized to be able to get the Pfizer vaccine. And the response to that was, in the United States, 1.6 million people a day for that first week or so, rushing to get their kids the first vaccine. And then about 3 weeks later was when they were eligible for the second. What happened was, in the United States and in Israel, which has a fantastically organized national healthcare system, they were seeing myocarditis. We have 7 cases here, which were enough to, again, trip the CDC to the health departments, to all providers, putting out the word that we were to be looking and listening for myocarditis among patients who had recently received the COVID vaccine, including the Moderna, which was not authorized for kids yet. Could I have the next slide, please? The pattern that we were seeing was that these kids were kids and young adults. They went from age 12 all the way up to 39 in males. They were roughly 4 times more common in males than in females. It was only a small percentage, a very small, roughly, it came out, I think, 1 in 50,000 second doses. But it was the second dose that seemed to trigger a myocarditis. And for our lay audience, myocarditis is inflammation of the heart muscle, which can then malfunction. It can also be pericarditis with myocarditis, which is the covering of that. Now, we saw that with SARS-CoV infection. And in fact, we saw that at a rate that was 16 to 18 times higher than the risk that we've ultimately figured out for vaccine. But every single patient who was getting vaccine at that point got a statement about the risk. They were encouraged to use both the VAERS reporting line, which was a passive reporting, so that the patient or the patient's parent would report that they had these symptoms and they weren't sure, and it was taken seriously and reported even as a not confirmed case to CDC. Everyone was included to use the vSafe, which was an app that you put on your phone where you were recording after your vaccine doses, every fever you had, every symptom you had, and they really pushed, as did Israel, to get everyone reporting in on how they did with this. Israel then came up with a retrospective cohort as through the national health system. We had over 800 US hospitals reporting both myocarditis with disease and myocarditis with the vaccine. And if I could go to the next slide, please. What we saw in myocarditis that was from vaccine was that it was much faster onset. It wasn't a late immune response. It was something that happened in 2 or 3 days. So this was something that if your child was vaccinated on a Thursday, you would know by the end of Shabbos or by Sunday if they were going to be getting something. It was way predominantly male, roughly 3 to 5, 3 males to about 1 female, 3 to 5 to 1. And the numbers that came up were that this was ages 20 really for the second dose, which was the most dramatic. It's been seen now, they have not yet pulled any out of the under 12-year-old group in studies, but the 12 to 18-year-old group, we have seen it. Now, the most important part, and I think that's my last slide, I hope, is the outcome of these. Because when you have the myocarditis following vaccination, most of the patients go home from the hospital by day 2. We looked at 2 things. We looked at the VAERS reporting, and they had 845 cases in the age group that I've indicated, 16 to 29. Of those, most of them met the case definition. At the report, which was done really 4 weeks after the initial reporting of the disease, over 3/4 had completely recovered. And by the time they were at the 8-week mark, they had all recovered completely. There were a further 98 cases mined by vaccine safety data, which is when you actually go into hospital records and you pull out ones of people who may have had vaccine associated, didn't report it themselves. Less met case definition. 100% of them showed the symptoms that were the tell, because they're not symptoms we see commonly in kids. Chest pain, pressure, and discomfort, not the mommy, I've got a tummy ache, or that Szechuan food didn't agree with me, but persistent symptoms like that. And some additional ones were dizziness or fainting. When we got them to the hospital, we saw that the ones that we did diagnose had heart enzymes that did say, yeah, something's going on with the heart muscle. Less so, but there were abnormal EKGs and echoes. But again, even in this group with these findings, 3/4 were home by 2 days. Some didn't even get hospitalized. In the more adult ones where they needed the bed, they went home. And 100%, you just don't get that in medicine, 100% were fully recovered by 6 weeks. So I don't think I have another slide on this. I think my next slide is a different topic, but the take-home message here, not this one. We'll wait on that for later. That we don't need any more of these slides. Is that yes, it occurs in vaccinated patients, but it occurs less frequently, and the outcome is universally good. And I think the other take-home message is that the CDC, the health department, and your providers who you've trusted before are on this. They're responding. We're all getting gray hair from it, but we're responding. And the best question to ask your provider always is, have you done this for your kids or your grandchildren? Would you do it? What do you believe? Because we're all on the side of it. We want this over with. We're sick of COVID. And with Delta involved, it's made it much more transmissible. It has been much more common to get infection. The head of the American Academy of Pediatrics section on disease dissolved in tears on a meeting, and that moved me greatly in Delta. He said, there are so many sick adults and we're so understaffed. My neighbor's father just died waiting in the 2-hour line to the hospital. And one of the patients that I knew who was trying to get to the hospital, who could have been turned around with just oxygen, died because people weren't vaccinated. It's time to stand up and get vaccinated and to talk to your doctor if you have particular exceptions. Thank you.
Thank you very, very much, Dr. Lipton. We now move on to Dr. Sarah Dienstag Becker. Excuse me. Dr. Becker is the Co-Chief Fellow of Child and Adolescent Psychology at Zucker Hillside Hospital at Northwell Health in Long Island, New York, and serves as the chair of JOMA's COVID-19 Vaccine Education Task Force. JOMA, again, is the Jewish Orthodox Women's Medical Association. In this role, Dr. Becker has arranged numerous vaccine town halls for different segments of the Orthodox Jewish community, authored several articles and guidelines related to vaccination, and collaborated with other leaders and organizations within the community to encourage vaccination against COVID-19. Dr. Becker, please tell our audience about the work that JOMA does and the resources available to us.
Thank you so much for inviting me here this evening. If I can have my slide, thank you, perfect. So before I begin about JOMA's efforts in COVID-19 vaccination, I just wanted to begin to say a few words about the organization itself. The Jewish Orthodox Women's Medical Association is a nonprofit organization that was founded to support from women, Jewish Orthodox women, physicians and trainees and medical students, and then to harness the combined force of these amazing women to raise the health of the Orthodox community as a whole. JOMA was founded in 2019, and its first foray into public health was during the measles epidemic, when JOMA developed the measles hotline to encourage MMR vaccination. Just months later, with the arrival of the COVID-19 pandemic, JOMA once again stepped up to share up-to-date medical information, both regarding prevention and treatment, as well as guidelines to safely reopen bedrocks of Jewish life, including mikvaos, Jewish ritual baths, and yeshivas and schools. Next slide, please. I'm sorry, the next slide as well. And so if we fast forward to December 2020, with the arrival of the COVID-19, the first COVID-19 vaccines, there was, I think, within JOMA and the healthcare community at large, both tremendous hope as well as fear. You know, would the community, would the public at large accept these life-saving vaccines? Or would fear and misinformation prevent them from doing their jobs? And so the JOMA COVID-19 Vaccine Task Force was born. Next slide, please. And we jumped into high gear right away and printed articles in print publications, as well as had digital PDFs circulating. And these are all available still on our website with information about the COVID-19 vaccination, both in terms of process and development, as well as trying to address concerns from specific populations. Next slide, please. We also had several virtual town halls, the first ones being in March and April. We tried to solicit as many questions as possible from the community at large and presented them to panelists of experts, including Dr. Naor Barzeev. And these questions were answered live at these virtual events. And these town halls are still available. Recordings are available both on our website, www.joma.org, as well as on our YouTube channel for viewing. Next slide, please. We're fortunate in JOMA to have Dr. Lisa Minkin, a pediatrician from New York, at the forefront of much of our preventative health work. Dr. Minkin hosts a weekly podcast on a wide range of health topics since 2019. And then with the introduction of COVID-19 vaccines, Dr. Minkin has devoted numerous episodes to discussing different aspects of vaccination, from general concepts to specific vaccine categories, such as expecting women, which is a very popular category, and also trying to understand why there are those who remain hesitant and how we could help, because that's our job. Our job is to try to help. We have these talks available on almost all major podcast platforms, as well as on our pre-recorded hotline, 929-4-GESUND. 929-443-9868, for those who prefer to avoid internet use. And then Dr. Meakin often takes these conversations further on Instagram, hosting Insta Lives so that people can get more behind the scenes information and get further questions answered. Next slide, please. We have many print materials. I'm sure many of you have seen these in advertorials in National Orthodox publications. We have brochures that we've distributed to medical offices across New York City and are available to order through our website as well. We've distributed information with the help of the Orthodox Union as well. And again, our role is really to try to bring as much up-to-date information to the community as possible so people can feel empowered to make the decision regarding vaccination. Next slide, please. And so that brings us to where we are now. October 7th, we launched our a new COVID-19 vaccination hotline, 843-VAX-INFO. That's 843-829-4636, where callers can call in and receive answers to their questions about COVID-19 vaccination. And since its launch on October 7th, we've received hundreds of calls and made many callbacks for people who wanted further information. Our role, again, is we're encouraging dialogue, answering questions. We also recognize that the best place for these conversations to happen continues to be in the community's own with the community's own trusted medical professionals and leaders, and to have the conversation in their own spaces, in their own offices and community centers. And so that's why, in addition to brochures that are available not just for doctors' offices, but for community centers, McBows, schools, wherever it is, we have information available. Professionals can also opt to receive our COVID-19 vaccine e-newsletter, which is geared towards providers and having these challenging conversations, but rewarding conversations in their own office and in their own time. Next slide, please. So again, thank you so much for having me here tonight. If there's any way that those of you listening, feel like JOMA could be of help to you, I really encourage you to visit us, in any way that you can, whether that's on our website, on our Instagram, on our YouTube, listening to our podcast, so that we can provide services to you. Thank you so much for your attention.
Thank you very much, Dr. Becker. And I am going to include JOMA's website information on our final slide. I know we are over our time at 8:30, but I would like to get to some other questions. If people are still willing to stay on and go longer, I think that would be great. So my first question is to you, Dr. Barzeev. What is the role of ivermectin in COVID treatments? And also, if you can go into beyond that, covering the monoclonal antibodies. Is a regular infusion of monoclonal antibodies effective as a prophylactic treatment for people who are immunocompromised? If you can cover those two things, please.
Sure. So look, ivermectin has effect in vitro at very high doses, but it's not been shown in studies that have been done carefully and rigorously conducted. Trials have not been shown to have any benefit in clinical practice for patients. And in fact, we've seen an increase in use of license for ivermectin, or use of veterinary ivermectin, that's used for sheep dip and so on. People have come in and been hospitalized with adverse effects as a result of high-dose ivermectin. Ivermectin is generally well tolerated at normal doses, but when people don't know the dose and they take it, it can get very serious adverse effects. In fact, life-threatening adverse effects can occur with ivermectin. So I would not encourage that it be used off license. Its role is continuing to be studied and has been studied in clinical trials. And if it was to be used in the context of a trial, perhaps for a specific outcome or indication, then within a trial context, I think that makes sense. And not just for ivermectin, but for many other therapeutics that are constantly under study. We really need to get good therapeutics for this disease, but ivermectin is not one that has proven itself to be efficacious. And in fact, unlicensed use can be downright dangerous. So I would avoid using it. With respect to the monoclonals, it's actually quite an interesting story with the monoclonals. Essentially, the monoclonals are antibodies, if you like, that are produced and they're given to the individual rather than vaccinating them and then have the body produce its own antibodies. We give the antibodies directly, and there are certain circumstances where that might need to be done. Initially, as there was the emergence of the beta variant and also the P1 variant, there was the gamma variant, there was a pause in the use of the monoclonals because they were less effective against those variants. But now with the dominance of the Delta variant, the monoclonals do have efficacy against the Delta variant. And in fact, there is renewed approval for use for certain monoclonals, either for prophylaxis in high-risk individuals who've been exposed, what we call the so-called pre-exposure prophylaxis, post-exposure prophylaxis, you've been exposed but you haven't got disease, or for the treatment of disease, mild disease, to prevent the development of severe disease in persons who are at high risk. There is not a lot of evidence regarding regular repeated transfusions or infusions of these antibodies to individuals. Obviously, there would be rare circumstances where a certain individual is unable to be vaccinated and where the risk is high, and under certain circumstances, individual practice may vary, but the evidence at the moment is, and the guidance, which is available online, you just look up the NIH clinical guidance, is that they have a role for people who are at high risk, who for one reason or another are unable to mount an immune response to vaccination. In such person, there's a role for the prevention of severe disease if they're at risk of complications. But again, for personal medical advice, of course, people should speak to their physicians, and the guidance changes all the time. So if somebody's listening to a recording of this in a few weeks' time, things may again be different. So it's important to update yourself and to speak to your treating physicians. Thanks.
Thank you very much, Dr. Barzeev. Let me get my video on. Thank you. Thank you very much, Dr. Barzeev. Dr. Lipton, the next question is to you. Where did the questions on fertility get started? And what are some data on safety and efficacy of vaccines for pregnant women and afterwards? And also if you have any information on the menstrual cycles being affected.
Sure, I'll start with the easy one, which is the menstrual cycles. Yes, there often are in the first or second cycle after immunization, some heavy periods or some interperiod spotting. This is probably a result of some inflammation. And if you're having a systemic, response where you are achy and the vaccine's having a take, it's possible, but it's very short-lived. It is certainly less than we see in COVID, the disease, and it's very hard to tease out. We know other kinds of inflammation can trigger increased menses, certain medications, homeopathics, and stress, which we've seen plenty of, can interfere with that. Now, I would refer people to looking, and it's written in, I think, the English that most even non-medical people can find. The Society for Maternal and Fetal Medicine, the Society for Reproductive Biology, and the American College of Obstetrics and Gynecology have been following prospectively women trying to get pregnant, women who might be pregnant, women who are pregnant, and through all 3 trimesters and outcome of women who get the vaccine. There's been nudge doesn't even come close. There has been real emphasis on plugging all of these women into the V-Safe application and tracking through the duration of the pregnancy. And they have 139,000 women matched with age controls and vaccinated around the same time. So the same community conditions existed, often the same hospital. And of these 139,000 women, including women who were in vitro fertilization having trouble with pregnancy, there is absolutely no difference between success of getting pregnant, of the implantation staying versus miscarriage, versus no difference in prematurity, And the only big difference is in the outcome of the mothers, because about 3% of women who get COVID disease will end up critically ill in the hospital. And of those, about 3% may die, often right as the baby is born. So I'm very impressed with this. ACOG and all the other organizations I mentioned have come out very strongly that women who are pregnant are much more susceptible to severe disease. We know, excuse me, that COVID is a disease that totally deranges clotting, and that's the last thing you want with the placenta, is either to have problems with too much clotting or at delivery problems with things being thinned out and too little clotting. The data is ongoing and anybody can access that and follow it.
Thank you very much, Dr. Lipton. The next question is going to go to Dr. McDowell. How can I trust the vaccines when Big Pharma is making so much money on them?
Thanks. I think that, that is a question that a lot of people have around how can I trust the medical system, the public health system, the government, and pharmaceutical companies as well. I think in regards to that question, it's difficult to answer because it really is how you feel inside about quote unquote Big Pharma. But we do have to think about the other medications, including therapeutics that were mentioned on this call, that are also developed by pharmaceutical companies with the mission to save lives or reduce disease and death from diseases that can be life-threatening. So in regards to trust, I think that what has been put forth by a number of the clinicians on the call is that the data itself is publicly available. So you can actually go to the FDA site and Google FDA Pfizer booster or FDA Pfizer booster brief, and the documents and the data will come up for you to look at yourself. Also, you can go and stream the FDA advisory meetings, which are on YouTube, and also the CDC ACIP advisory meetings as well, to hear that debate and also the analysis of the data by scientists international and also nationally. I do completely agree that we, in looking at this information, need to be informed. We need to see where the sources are coming from, and we need to have critique and open debate around this. And there is transparency, there is open debate, scientific debate that is taking place, which we can all participate in. The FDA and CDC also provide opportunities for the public to speak to the pharmaceutical companies, for the public to speak to the FDA, to speak to CDC about concerns. So I think in regards to trust, we have to really, there's a balance, because a lot of our pharmaceutical companies are making therapeutics that were mentioned and that have been beneficial across the board, but then also just being open to the transparency that really is there, that has been there from the beginning, taking advantage of that, reading the documents, participating and listening in on those calls, and then going back to your healthcare provider or someone that is knowledgeable around the vaccine to answer those questions.
Wonderful. Thank you, Dr. McDowell. We've covered a lot of ground tonight, and I would like to thank our panel of experts for giving of their time to be here tonight and addressing the audience's questions. There is a lot of misinformation going around. Oops, hold on one second. Sorry, my screen went off. There is a lot of misinformation going around about COVID-19 and vaccination against it, and I hope that what we've presented tonight helps to better understand this disease, its effects, and the safety and importance of vaccination. We are putting up on the screen a list of resources where you can find more information as we continue through this pandemic. Please educate yourselves through the most reliable resources, ask your medical providers when you have questions, and stay safe. Good night, everybody.
Thank you. Good night.